Welcome to Clinical Convos, a show that provides bottom line answers to key stroke recovery questions. I am your host, Henry Hoffman, an occupational therapist and co-founder of Saebo, a leading provider of stroke rehabilitation products. If you are a health professional or a caregiver and want to get to the bottom line regarding effective treatment options, then you've come to the right place. This is episode 3 at Clinical Convos, and I'm excited to discuss a topic that many patients and therapists may not be aware of. When we think of stroke treatment to improve arm and hand function, many folks typically do not consider vagus nerve stimulation, or VNS, as a top option for recovery. To discuss all things VNS, I have the pleasure of bringing back Dr. Steve Wolf, who is not only a pioneer in the stroke rehab research field, but was also one of the co-investigators of a recently published study looking at VNS and upper limb motor function. Dr. Wolf is a physical therapist and a neuroscientist. He received his PT training at Columbia and Boston universities. And by the way, I won't ask what the tuition costs were for that. And his doctoral training at Emory University, where he is a professor in several departments. Within the past 23 years, he has co-authored hundreds of research articles and has led several NIH-funded clinical trials in stroke rehab, including the famous CIMT study. I'm excited to have Dr. Wolf on Clinical Convos today. Dr. Wolf, welcome. How are you?
Fine, thank you. It's a pleasure to be here.
Yes, pleasure to have you. I'm eager to discuss VNS with our audience today. How about you? Do you want to get started on that?
Sure.
All right. Well, the first question that I know a lot of people ask is, what the heck is VNS? I know it's vagus nerve stimulation, and I know you're stimulating the vagus nerve, but I was hoping you can, since the audience is primarily patients and therapists and caregivers, if you can describe how it works and who it's used for.
Well, first you have to have an understanding what the vagus nerve is. I'm sure we've all heard of the fact that there are what we call 12 cranial nerves. Some of them are very familiar with you, to you. The optic nerve to see, the auditory nerve to hear, as examples. There's one nerve, the vagus nerve, which is actually located in our neck, comes from our brain to our neck, and then diffuses and goes to many different places in our gut and all of our organs. As a matter of fact, it's a major nerve for controlling parasympathetic activity, slowing things down in our nervous system. But what we didn't realize until recently is this vagus nerve, and by the way, vagus means the wanderer. It's a wandering nerve, and those portions which go upstream to our brain spread out into different areas of our brain, so that when the nerve is activated, it stimulates nerve cells to go to our sensory and motor cortex, of portions of our brains where we feel things and initiate movement. And what is potentially very unique here, and why some of the work seems to be very promising, is because we think we are now activating nerve cells that we don't traditionally activate with the kinds of therapy that we do with straightforward movement, electrical stimulation, where we have a clear input from our sensory nerves to our brain and back down from our brain. We think we're bypassing some of those nerve cells and now finding ways of activating nerve cells that are still alive after a stroke, but haven't been activated before. And so the combination of doing this stimulation in synchrony with a movement that's functionally related is a key factor to what might be leading to the success. And what we'll be discussing in a few moments is, how do we know that's really true? What's so special about the VNS as opposed to just doing task-specific practice?
Right. Well, that's really good. Thank you. I think that will help the audience understand a little bit more about what VNS is. Now, I've heard, and I know some patients have heard from therapists, there's implantable VNS, and then there's also non-invasive. And we've seen these before where they clips electrodes or pulses to ears, I think somewhere on tongues. So it's been peripheral versus implantable. Can you spend a few minutes describing the difference?
Of course. So let's go with the simpler one first, the non-invasive kind. Sometimes it's called auricular stimulation, which is a fancy way of saying put some sensors or electrodes around certain portions of your ear and stimulate those portions of your ear. Well, why would we do that? Because we know that some of this vagus nerve I was just talking about provides sensation to the ear. And the idea here is, why not stimulate the ear rather than doing something more invasive, and just use that as our form of vagus nerve stimulation going up to the brain. Well, there are two reasons why that's not as potentially not as effective. One is the distribution, the amount of nerve cells to the ear is far less than what we could access directly if we stimulate the vagus nerve. And secondly, the variations in the location of those nerve cells in the ear is so great that we don't even know for sure. If we find fixed points that we stimulate, we're activating the maximum number of this limited number of nerve cells for the vagus nerve. So the potential impact may not be as great. The invasive kind of stimulation sounds terrible. It is a surgical procedure in which a patient is anesthetized. There's a small cut made near the vagus nerve, near your carotid artery, just in the skin, because the vagus nerve lies behind the carotid artery. These electrodes are put in that, around that nerve, the entire vagus nerve, and then led down on your chest to a receiver. It's actually going to receive a signal to stimulate through those leads into the nerve. That sounds terrible. It sounds complicated. The total procedure surgically is about 15 to 20 minutes.
Wow, that's it.
And that's it. And in terms of a concern that we should have as patients is, well, is that bad? Is something bad going to happen to me? The worst side effect recorded now in hundreds of patients who have received the implantable vagus nerve stimulation is some transient, short-term hoarseness of the throat. Hoarseness of the throat, what does that have to do with anything? Well, some of those nerve fibers from the vagus nerve also supply the muscles that help us with our voice and our tone. I mean, we have muscles that allow us to speak and be heard in certain ways. And those could get slightly affected so that the patient claims to have hoarseness that may last a day or two. That's about as bad as it gets. In terms of long-term infections or other things, very little adverse things can happen.
All right, so it sounds like from what I'm hearing is, although peripheral stim, where it's on the earlobe, has been around for a while and it's clearly more convenient, it sounds like the results are not as effective as potentially, and we'll get into research in a little bit, as the implantable, which again is not a significant intervention, but it takes a surgery and it's about 15 or 20 minutes. And those results seem to be a little bit better, but that's the implantable version.
Just because we can now access the entire nerve rather than just not knowing exactly how many of those nerve fibers we can affect by stimulating the ear.
Got it. All right, let's dive now into the actual VNS study, which you co-authored. It was recently completed looking at arm and hand function following vagus nerve stimulation for stroke. Can you touch on the highlights of the study so we can learn more for the audience?
For a study of this magnitude, this size, to be important, it's got to be very well controlled. And you have to be able to demonstrate that if this vagus nerve stimulation combined with task training is to be effective, it has to be demonstrated in multiple sites, not just one place. And that the work has to be blinded. What does that mean? That means that the person delivering the therapy and delivering the stimulation cannot know whether the stimulation is really on when the person clicks a button to activate a small pulse to the vagus nerve. So all patients get the same amount of task training, like occupational, very much like task-specific occupational therapy, but only half the patients receive the real stimulation at the same time. The therapist doesn't know, the stimulator person doesn't know because it's been pre-programmed, and we only find out after the patient has completed all of their therapy, which is 3 times a week, for 6 weeks, 18 sessions. And then they go home for another 18 sessions for further therapy. They're instructed how to do this in the home environment. And then we look to see how much people have improved on very specific functional tasks, tests which we use routinely in assessing our patients. And then we determine, is there a relationship between the application, the actual use of the vagus nerve stimulation with task training versus fake stimulation with task training?
Got it.
So in terms of the outcome of that, we're pleasantly surprised to see that without question, it didn't matter which facility was participating. When we looked at the data, the amount of improvement in a test called the Fugl-Meyer test, and the secondary test, which is called the Wolf Motor Function Test, it's named after me, both showed statistically significant improvements only in those individuals who had the vagus nerve stimulation coupled with the task-specific training, compared to the fake stimulation coupled with the task-specific training, which means that the vagus nerve stimulation must be making a major contribution to explain why the difference in the size of the improvements.
That's wonderful. That's wonderful information and exciting outcomes to see, especially with the double-blind format there. So it appears that VNS, along with, and you mentioned the right rehabilitation, because if it's paired with rehabilitation, most patients can argue, well, yeah, I've had a bad therapy experience. My rehab was not great. So would VNS work with the therapy experience I had, or is it another type of therapy experience? So what in your mind is the right paired rehabilitation?
I don't exactly know what is right. I can tell you what we did because we think it's right. There are a series of tasks, and all of the therapists who were participating in the study in all 12 or 14 sites around the world, the United Kingdom and the United States in particular, were trained on which tasks, there were selected tasks, and how to administer them. So there would be very little variation in what's going on from therapist to therapist or center to center. One or two of those tasks were freebies. The patient could specify what they want to do. And by the way, all of these tasks were documented as to how much time was actually spent on each one and how often. We knew that because the therapist would document the task, and we can count if all those stimulations, fake or real, were recorded in real time. So we know how many times for each time there was a pulse, there was also an activation on the part of the patient to do that task.
Right, so you can time the task with the stimulation, which seems to make the most sense.
Know how many times a task was tried each day the patient was doing their task.
Right.
So now what we haven't done yet is look at the relationship between, is there a relationship between which tasks the patient spent the most time on and how much they improved? That's an important question to address because you're wanting to know, and I think all of our patients would want to know, well, what should I be doing, which is best for me? And we don't have that question. But these kinds of data that we're going to be looking at now will help us inform everyone that those patients who improve the most spent the most time doing tasks A, B, or C. We don't have them yet.
Right. Well, putting my Saebo, not hat on, but shirt on, I would say, think about those patients maybe for future studies that don't have finger extension or they have severe spasticity. It's hard to do task-specific training with them because they don't have the adequate hand mobility. So from that perspective, it would be neat to see, well, what if you put them in a finger extension assist orthosis, kind of like this guy, or the Saebo-Flex down here, and also combine it with VNS, for instance, in this case. And what would happen to that population? Because we know that population is a huge population. Of course, the ones that do have finger extension and the ones that, let's say, qualify for CIMT, that's not a majority of the stroke survivors. And it's good that we can help them, but it certainly would be nice to help the majority which do not have any finger extension, hand mobility, or they have severe spasticity. But in general, it sounds like the VNS seems to be very promising and potentially helpful to improve the lives of millions of stroke survivors worldwide. Steve, is it currently available now commercially for patients? And if not, when will it be available? And if you can mention a few things about cost or insurance.
So it's nice to see that you're a walking advertisement.
Yes, I don't even need a PowerPoint presentation anymore. I just point to the slide.
Can't imagine what the rest of your wardrobe looks like.
It's from that stuff.
But you've asked several questions. And I think one important one is, who's really eligible for this intervention to be successful? And it's impossible to answer all those questions in one study. So the patients that were used here are individuals who could begin to demonstrate movement out of synergy. The question you're posing is a very interesting one. Well, that's nice, but a lot of patients have tightness due to spasticity, muscle shortening, weakness. What about them? Might they benefit from vagus nerve stimulation, which I think is part of your question? And the answer is we don't know, but it's very inviting to ask the question. If we complement vagus nerve stimulation in those patients with another therapeutic, such as a Saebo-flex, can you then, instead of the task specific, using the Saebo-flex in a task related manner with the stimulation, can we increase the amount of functionality that patients have above and beyond what they gain just by using the Saebo-flex alone? And we don't know the answer to that question. That's something worthy of further exploration. And I can't speak for the company that funded this work, but I cannot imagine them not wishing to go further to explore and raise their game and see how many more patients with further impairments, limitations might benefit from this vagus nerve stimulation.
Right.
In terms of its eligibility, what's going on with this now, it's a very timely question because last week, the microtransponder, the company that makes the VivaStim system, which is what it's called, was given FDA approval for its application to patients with stroke, which means that now this can be farmed out and used in clinics around the country for that matter, presuming that the neurosurgeons who would do the implants are trained. And I've talked to several neurosurgeons already. To them, this seems a pretty fundamental surgical procedure compared to many of the other things that they do. So that's not the question. I think we're going to start to see next year is more and more clinic neurosurgery partnerships adopt this procedure and its utility. In terms of how much is it going to cost, I can't answer that question. I've been told, I don't know as a fact, that the time for the neurosurgery, which as I said was 15 to 20 minutes, the operating suite time, the nurse's time, et cetera, that cost alone right now is about $10,000.
Okay, and does insurance cover it?
Pay for it? Sorry?
Sorry, does insurance reimburse yet for it, or are they going to?
Well, that's the question. So I don't know. Okay. I'm going to guess now that the FDA has approved of it. I suspect that the next procedure is to gain Medicare approval or other insurance agency approvals, because this is now a procedure recognized by the FDA.
Great.
So I'm trying to project into the future. I don't know that to be a fact yet.
All right. So
how much it will cost of the therapist's time, that I imagine might be comparable to what is now being done as therapy time for task training, perhaps billed as therapeutic exercise. Pure conjecture on my part at this time, Henry, but it seems reasonable to think that that's what will happen.
All right. So the bottom line for the audience is it's a promising intervention, very early stages, to be determined as far as insurance reimbursement. They need to stay tuned, but this is something for them to keep an eye out for sure. Yes. Well, that sounds fantastic. This has been a fantastic discussion, and I appreciate your time talking about VNS therapy today. Do you have any final thoughts or comments about this intervention in general?
I think all of us, laypersons, care partners, and clinicians should keep an eye out for the progress that will be occurring with this procedure. I know, because I happen to be involved in two major presentations that have already been accepted as major presentations at the American Congress of Rehab Medicine meeting at the end of this month, and at the combined sections meeting of the American Physical Therapy Association. So there is an awareness on the part of clinicians and researchers that this is an up and coming procedure, and there's a willingness of the clinical community to learn more about it. I think the biggest concern I have right now is to convince care partners and patients that when they hear neurosurgery, this is not the typical neurosurgical procedure. This is implanting an electrode into a nerve, quite a very superficial nerve, that doesn't require a great deal of time. I would add something that's important. Is this dangerous? What's the long-term consequence? The implantable receiver in the chest, well, that can be removed anytime. What surgeons have opted to do, and the patient should listen to this very carefully, is if someone wants this removed, everything but the actual electrodes around the nerve are taken out. Why don't you take the electrodes out? Because there's connective tissue that forms around these nerve cuffs, and you don't want to run the risk of damaging the nerve at all by
Right.
pulling on the connective tissue. Does it hurt? Do you know it's there? No. But
Okay.
people should understand you deliberately don't remove the probes, the electrodes that are wrapped around the nerve, because you
Right.
don't want to damage the nerve. There's
Right.
no long-term consequence or harm to the patient that's known of at this point in time.
Excellent, excellent. Well, that was very helpful, and thanks for that additional comment. All right, for the folks listening, if you enjoyed this episode or have any comments or experiences you would like to share, please post your comments on any of our social media sites to let us know. Also, if you have any questions for me about our technology and how to obtain a free trial, feel free to reach out to me at hhoffman@saebo.com. Steve, thank you so much. As it's always a pleasure having you on. You're a wealth of information, and looking forward to our next episode together. And
Me
I will
too.
see you next time. Thank you very much, Steve.
Thank you for having me. It's been a pleasure. Bye-bye
Okay.
now.
Take care.